And it can be used also, and that's very important, to redefine conditions of use or conditions for reimbursement, or to review the price. For instance, we have reviewed the conventional X-rays, for instance, chest X-rays, because it was noticed that there were a lot of conventional chest X-rays performed, and then after that, a CT scan was performed because it was the exam that should be performed in the first place. So we had to review what are the real indications that remain today for these conventional X-rays. We reviewed also the drug-eluting stents, indicating that their benefit was confirmed but was very limited, with, for instance, no benefit on mortality. And that's a very important part of our activities. So regarding drugs, we have a rule in France. We like equity, and all drugs have to be treated the same. So the way we function is that we have a positive list of reimbursed drugs, and it is mandatory for all drugs to be assessed by HAS before a decision is taken on the price and on the reimbursement. The prices are regulated, as opposed to the UK. We are a price-setting country, not a price-taking country. So that's something that is important. The negotiating pricing committee is called the CEPS, Economic Committee for Health Products, and it negotiates and decides on the price on the basis of our assessment and appraisal of the drug. And there is a link, of course, between our opinion and the decision from the CEPS, from the Economic Committee, from the Pricing Committee. And the review every 5 years, I've already mentioned it. So our guidance, our HTA report, is transmitted to 3 decision makers: the Economic Committee for Pricing, the Ministry of Health for the decision and the publishing of the decision on the official journal of the French Republic, and for the National Health Insurance Union that will decide on the level of co-payment for the drugs. So what do we have in our HTA report, in our HTA guidance? We have 5 points. The first one is to answer to the question, is the drug eligible or not to reimbursement? And for that, we look at the disease characteristics. Is it severe or non-severe? And to the effectiveness of the drug. Is it important or not? But it's not a comparative judgment. It's really an absolute judgment about the level of efficacy of the drug. And combining these 2 things and looking also at the potential interest for public health to have this medication reimbursed, we conclude whether the drug, the committee, the committee for the assessment of drugs, called Transparency Committee, concludes whether the drug is eligible or not. If it's not eligible, okay, end of the story, and the decision will be probably negative. If the drug is eligible, we look then at the added clinical benefit, what we call ASMR, Amélioration du service médical rendu, and we rank the added benefit from level 5, that is no added benefit, to level 1, that is major added clinical benefit. And that's something that will be used by the Economic Committee for setting the price. Then an important point also is to estimate the target population. How many patients could potentially benefit from this drug if it is reimbursed? Then we look at the very important question of uncertainty, because at the time of the initial assessment, there are always data that are not there. You have a limited patients that have received the drug for a limited period of time and so on. And we analyze this uncertainty, and we can make, if necessary, the request for additional observational studies to be performed to reduce this uncertainty at the time of the reassessment of the drug. And the final point is not for the public decision makers, not for any public committee or ministerial committee. It's for health practitioners, it's for prescribers, it's recommendations for the use in clinical practice of this new drug. So we can make requests for additional data collection. I'm just mentioning that we made a lot of requests from 2004 to 2010 for drugs and for medical devices. The success can be discussed, but we have no time to do that. But in many cases, it was useful for the decision makers to get more data on the drug. So that's to indicate how we function, and I think I have 2 of them. So I'm not going into detail, but it's just to show that the dimension we are looking at currently for the initial assessments are clinical, and more clinical, and you don't see any economical analysis for the time being in this initial assessment where you have only 90 days and limited data in our hands. We conclude mainly first on the eligibility and then on the added clinical benefit. And then another body, the Economic Committee, takes that into account to determine the price. And by the way, it is the very similar system that has been implemented recently, less than 2 years ago, in Germany, where they have now a criterion on added clinical benefit that is exactly the same philosophy as ours. And then another body, in their case it's the National Health Insurance Funds Association, that negotiate the price with the company. Okay, so what do we do after that? What do the decision makers do with our advice? So the decision makers, and I'm particularly focusing on the CEPS, the Pricing Committee. There are rules governing the price that is decided, that is a fixed price, a decided price in France. So it's a contract between the company and the CEPS, or if there is no agreement, it's a decree, a decision by the CEPS. And what are the primary considerations when setting prices for the committee? The first one is the added clinical benefit. What is the rule? You see that on the last bullet point. Drugs that do not provide an added clinical benefit cannot be reimbursed if they do not bring some savings to the system. So that's the deal. Either you bring a progress and you can have a price that is higher than comparators, or you are judged as being eligible for reimbursement by HAS, but not having shown any added clinical benefit, then you can be reimbursed, but you have to be cheaper than comparators. So that's the rule, very basic rule. So we have also something important, that is the price volumes agreements that are made at the level of the EPS. That's why it's important that we assess the target population. And if there is overshooting with more patients receiving the treatment that it was allowed in the contract between the CEPS and the company, there will be some payments to be made by the company to the social security system, some clawback payments. So we finally have a system that is a bit of a hybrid between something based on the assessment of relative effectiveness on added clinical benefits, but also we have some reference pricing system, because for drugs that have a high level of added clinical benefit, they can get, if we are simple with, they can more or less get the so-called European price. And for drugs that have a minor or no added clinical benefit, then it's an internal reference pricing system looking at the price of comparators in France. So that's it, and to conclude, I would like to show some changes that are ongoing and what are the prospects in France. First, I had mentioned that there were no economic analysis currently in the process of the initial assessment of drugs. There can be some when we reassess a class of drugs. That's what we've done, for instance, with statins. We have made economic assessments. We have made a full HTA report for when we were reassessing growth hormone for children that are not deficient, because there were also some ethical questions and so on, and also some economic aspects. But for assessment of new drugs, to date, there is no economic assessment. But it's going to change, because a new law was passed at the end of 2011, and in October 4th, so that's a few days ago, that's a week ago, the decree was published indicating that now, for some drugs, not all drugs, HAS will have to perform an economic assessment that will be taken into consideration for the decision and the pricing of the drug. So things are changing, and they are changing everywhere. So, as you know, in the UK, that is the example, well-known example of a price-taking country, performing economic assessment and cost-effectiveness analysis based on the price decided by the company. Things will change also in the opposite way with the value-based pricing that should be introduced in the next future. So despite the fact that we have very different systems, we have some convergence that may occur in the future. So we take that into account, and we think that the international environment and the change towards value-based pricing in the UK is likely to influence what happens in France. And so we still have some issues to address beyond the measurement of clinical added benefits, that is looking at efficiency, That's what we are going to do now, according to the new law and decrees, organization of care, and taking into account social values. So we will, not we may, but we will increasingly contribute to these assessments. So I mentioned, however, just mentioned that changes are ongoing in France, but also in other systems, and that I will explain in my next presentation that despite the fact that we have different systems and different criteria for appraising the drugs, there is plenty of room for useful cooperation between HTA bodies, but that's another story that we'll talk about later. So as a conclusion, with or without HTA, I think you can, if you don't like HTA, you can just believe what people tell you. And I don't know if we can read, but it's written there, our coffee is an experience that chalk is unable to convey. So a drug company may say to the system, our drug is so good that we can't show you with real data, but it's so unique that you can take it. Or you can have the risk to go to the cheapest option, and of course, these sign makers may be cheap, but I may have the best prices in Scotland, but I'm not sure that I would like to have a sign like that if I want to advertise for something. So thank you very much indeed. That's the conclusion, and thank you for your attention.
Professor Christensen. Yes. Yes. Now, Professor Christensen will pokazat će nam dakle, perspektivu Europske mreže za procjenu zdravstvenih tehnologija. Professor Christensen, floor is yours, please.
Good morning, here I am again. You may remember, some of you, I was also lecturing yesterday and trying to give some new perspectives into this topic. I was asked to particularly tell you about the European experience of collaboration among the HTA institutions. We work according to this definition that was also shared yesterday. It's important to emphasize that HTA has the intent to have a broad scope, not only focusing on the clinical outcomes, but have a broader scope in its assessment of consequences of the technologies. It's important also to emphasize the transparency and the unbiasedness of the work. Again, it's not prescriptive, it's not telling what to do, it is informing the decision processes and the prioritization. And it only works in the fields where there is some research-based information to have as a basis for the assessment. There are other parts of policy that are taking in other aspects that are not underbuilt by research that is outside of HTA. One of the challenges that we have seen since the emergence, especially of doing so-called systematic reviews, that is to do systematic search of the literature on specific topics, analyze the quality of the research and bring it together. If it's based on trials, it may even be possible to do so-called meta-analysis, that are statistical methods to bring results from several trials together to get a better impression of the real effect of an intervention, be it a drug or a surgical intervention. And in order to work efficiently in the area of HTA, a former Director General of the American Federal Agency, AHRQ, Eisenberg, he said that we should work to globalize the evidence. We should share the evidence, bring it together in forms that can be shared across, and then we should, in each of our cases, localize the decision. That means we should find out where exactly are the decisions made in our specific setting. So, for example, in Creator, where are the decisions made on the application of new technologies?